So let's talk about lung cancer screening. Where do I point my... So I have no disclosures that are relevant to the discussion today. So just some very brief background. I think we all know this, but just to kind of touch on some basics, we all know that lung cancer is a major problem in the United States and actually in the world. It's the second most common malignancy in the United States, but is the leading cause of mortality from malignancy in the United States and globally. We know its prognosis depends upon stage, and the question then becomes, does earlier detection with screening lead to finding earlier stage cancers and improving outcomes? We know that about 1 in 5 people in the United States smoke, which is about 46 million Americans. And smoking is the #1 risk factor for lung cancer, with about 85% of lung cancers being caused by smoking. If you total the current smokers and former smokers in the United States, it actually doubles the number from the current smokers at people who are at risk. So it's about 94 million Americans who are at risk for developing lung cancer. And we know there have been a ton of screening trials that have been done before, focusing on various different modalities in screening, including chest X-ray sputum cytology compared to usual care, chest X-ray sputum cytology compared to chest X-ray alone. And while some of these may have detected cancers using chest X-ray or sputum cytology, they did not result in any mortality difference. And so screening really had not had any formal recommendations going forward in terms of any benefit. So the question became, with progression in technology and the development of CT scan and low-dose CT scan, can that modality detect lung cancers early and improve outcomes? So that led to the National Lung Screening Trial, which was a collaboration between the American College of Radiology and the National Cancer Institute. And this was the largest randomized largest randomized trial that was done in the United States for a total of about $250 million. So what was the eligibility? So patients that were enrolled in this study were between the ages of 55 to 75. They were either current or former smokers of greater than 30 pack years, and they had to have stopped smoking within the last 15 years. They had to have no prior history of lung cancer and no prior malignancies that would put them at risk for metastases from that malignancy within the preceding 5 years. So what was the design? So they randomized a total of 50,000 people, 25,000 roughly per arm into CT and 25,000 per arm into chest X-ray. At the time of enrollment, the patients received their CT scan and chest X-ray, and then going forward, they had an annual CT scan or chest X-ray for up to 3 years, and then after 3 years, they were followed forward with a plan going forward to follow them for 10 years. So this component of the study was relatively straightforward. What became kind of the Herculean effort for this trial, and really where a lot of the time and effort was devoted, was making sure that this follow-up across 50,000 patients in the 2 different arms occurred so that the final outcomes could be assessed. So the primary endpoint was looking at lung cancer-specific mortality, powered to detect a 20% difference between CT scan versus chest X-ray at detecting lung cancer and improving mortality. Secondary outcomes looked at all-cause mortality, the incidence of lung cancer detected in either CT scan or chest X-ray, and the distribution between the 2 different modalities. And then some other secondary endpoints which still wait for reporting. So what was defined as a positive screen? A positive screen was defined as a non-calcified pulmonary nodule that was greater than or equal to 4 millimeters, or based on the radiologist's interpretation that the findings on that scan were somehow suggestive of malignancy, even though it wasn't a typical pulmonary nodule. A negative screen was a non-calcified pulmonary nodule that was less than 4 millimeters, a morphologically benign nodule, such as a nodule that may have had calcifications in it, or other abnormalities that were not suggestive of malignancy. So across the United States, there were 33 centers that enrolled patients in the trial. About half of those centers, and I think this will be an important part that will come back later in the discussion, collected biospecimens, and so blood, urine, and sputum were collected in order to utilize these going forward as biomarkers to assess other factors that may allow us to incorporate into the screening process. So if you look at the screen positivity rate, now looking at CT scan versus chest x-ray, again, there were roughly 25,000 patients per arm that were screened. Across all three screens in the 3 years, it was roughly 25 to 30% of patients in the CT arm had a positive screen versus around 5 to 10% in the chest x-ray arm. So that across all screens, about 25% were positive by CT, and about 5 to 10% were positive by chest x-ray. So we were able to detect more pulmonary nodules in patients that had CT scan versus chest x-ray, about 3 to 4 times as many. But what are the significance of these? When you then look at the actual detection of lung cancer per arm, of the 25% that ended up having a positive screen by CT scan, only a small percentage of those ended up having a lung cancer. So roughly 95 up to 97% of the nodules that are detected are benign nodules, with around 2 to 5% or so ended up being a positive for malignancy in the end. So there's a very high false positive rate detected by CT scan. So if you look at the total number of cases then by CT scan versus chest x-ray, low-dose CT scan detected roughly 1,000 lung cancers by CT and roughly 940, so there was a favorable detection of lung cancer with the pulmonary nodule by CT screening. When you look at the stage distribution, with the yellow being low-dose CT scan, the green being chest x-ray, across most of the stages that were ultimately found, most of the early stage lung cancers where there was a difference were those patients who had stage 1A. So CT scan was able to detect an earlier stage distribution than was chest x-ray. This is looking then at the primary outcomes. When you look at lung cancer mortality, low-dose CT scan over the course of the 6 years where the difference was finally detected and the study was stopped, was about a 20% mortality difference compared to chest x-ray. So again, the relative reduction in mortality was roughly 20% by CT scan compared to chest x-ray. This resulted in a number needed to screen of about one patient in every 320 in order to detect a lung cancer, which actually is good performance characteristics compared to some of the other screening studies that are used. So for example, mammography, depending on the age distribution you look at, but if you look across all age distributions, it's roughly about 1 in 700 to 1 in 1,000, depending on the age, where a breast cancer must be detected, and colonoscopy is also about 1 in every 1,000. And so this actually compares rather favorably to each one of those other screening modalities that are used. When you look at all-cause mortality, there actually CT scan resulted in a death reduction compared to chest x-ray of 6.7, and when you factor out the lung cancer deaths, there was still a 3.2% reduction in death. However, that was not statistically significant. And I did mention this before, that CT scan did result in a favorable stage distribution identification at the earlier stage compared to chest x-ray, with about 70% by CT at early stage versus about 55% by chest x-ray. So based on these findings on the National Lung Screening Trial, the various societies in the United States basically made some formal, if you will, recommendations or guidelines based on that data. So, for example, the American College of Chest Physicians, the American Society of Clinical Oncology, National Comprehensive Cancer Network, and the Society of Thoracic Surgeons, all in review of this data, and I probably have forgotten a few of these societies, recommended a discussion with patients who meet criteria for the NSLT. So patients who've been former smokers, greater than 30 pack years, have been within the age group of 55 to 70, and again have quit within that 15-year time frame, to have a discussion with them about lung cancer screening and what that screening may be, the high false positive rate, and how you may proceed forward, This was then followed forward by recommendations by the United States Preventive Services Task Force this past August with an article in the Annals of Internal Medicine actually making a positive recommendation for lung cancer screening going forward. So I think what we will see probably in the next couple months is that this formal recommendation will be made, and then lung cancer screening may become a reality going forward. So I guess the question is this the end of the debate and the discussion? And I don't think it's necessarily that simple. So there's a lot of remaining questions. If you recall the way the study was designed, this screened patients for 3 years. Most of these patients, particularly if they fall in that younger age group of the 55 to 75 age group, they have obviously many more years within their risk profile for developing lung cancer. So as a result, will we screen patients every year going forward through the course of their risk profile? And if we do that, does that change the risk-benefit ratio for screening? And then the second question is, if we do screen these patients longer than the 3-year interval, is annual screening the right time interval? So should we be screening them every other year? Should we be screening them 18 months? And will those time intervals then change our ability to detect early-stage cancers? So we know the biology of malignancies differs from patient to patient. And so if you change that screening interval, more aggressive malignancies may be missed within a time frame at which they're detected at an early stage as opposed to a later stage. So we may actually see a stage shift to detecting earlier stage cancers as opposed to, not earlier stage, more indolent malignancies as opposed to more aggressive malignancies if we change that time interval. How about implementation challenges? At least as of now, there still has not, to my knowledge, been any cost-effective analyses to demonstrate whether this screening truly is a cost-effective approach. The patient selection and access, so there certainly are the inclusion criteria that were qualified for the National Lung Screening Trial, but what about the patient who smoked 2 packs a year for 35 years but quit 20 years ago? So we certainly know that patient is at a high risk for malignancy, but how do we select those patients going forward that still have risk but may or may not be covered by screening recommendations? At least as of now, there are institutions that are offering screening programs that are either out of pocket or actually are being offered free of charge. And obviously this may change if the Preventive Services Task Force makes its formal recommendation. But at least at this point, these programs that are doing these screening programs for free, is there a pressure on those programs to push forward with more invasive modalities that you may not choose in order to cover the cost that they're putting forward for their screening programs? Patient navigation, how will we get the patients into the screening programs and how will we track them through the process? And then in terms of workforce, you can imagine the estimated number of patients that at least fulfill the lung cancer screening trial criteria is estimated anywhere from 8 to 12 million patients in the United States. So if you take those numbers, how will the provider workforce be impacted in terms of scanner access, radiology, reading these? Will these patients need to be followed by pulmonary, by thoracic surgery, by their general physicians? So that the navigation from a patient and a provider perspective all needs to be thought about and worked through. And then we know that the risk factors associated with these patients is smoking. So for those people that are still smoking, as part of these screening programs, as they're developed, should we be incorporating into them a broader care of these patients? So should we be incorporating smoking cessation programs? Should we be incorporating evaluation by a pulmonologist for other associated lung disease with smoking? So evaluating for COPD, making sure these patients are potentially on appropriate therapy for other underlying lung disease that may accompany their current or former smoking. How about quality? So how do you ensure quality in terms of screening? So we know that screening penetrance across the population that is at risk varies depending on the screening modality. And so for those people that are at risk and would qualify for screening, how can we ensure they get what they need and that they get what the quality that they're required in those particular screening studies? How important is it that the nodules that are detected are done standard across all institutions? And so we obviously have the National Lung Screening Trial Centers. which have high volume centers and reading pulmonary nodules. Is that the same interpretation that would be occurring in community settings and in community hospitals? And would the information getting back to the physician that ordered the scan be the same in terms of the next steps that they should take? And so there have been some centers that have been trying to standardize a reading program. A lot of this has been done at the Leahy Clinic, where they develop what's called a RAD score. And then based on that, it's an attempt to standardize interpretation of the pulmonary nodules that can be used across all centers so that we're all talking the same language about what a pulmonary nodule is and what it means. We also know that the rate of biopsy for benign lesions, when you look at other screening studies that have been done, varies from institution to institution and across centers. And then complication rates from biopsies also vary. Higher volume centers tend to have lower complication rates. And so if screening becomes across all centers and the interventions on those is across all centers, will we be changing and impacting patient complications based on lower versus high volume centers? So there are other low-dose CT trials that are continuing to accumulate data to hopefully answer or complement possibly some of the information that we currently have. So this is the lung cancer screening trial. Most of these trials are European trials that are still ongoing and enrolling patients. Again, that may support some of the outcome of the lung cancer screening trial. The Nelson trial is actually evaluating nodules based on volumetric measuring as opposed to just two-dimensional measuring, which is done by the lung cancer screening trial. So there may be more information that comes out of these trials that change how we think about interpreting the scans, interpreting the risk for these patients. So in conclusion, the lung cancer screening trial has shown that CT screening can decrease lung cancer-specific mortality, but that comes at the cost of a high false positive rate. There are multiple analyses still ongoing, some of those analyses being cost effectiveness as well as biomarker analyses. I think what will be a very important component of this going forward, and it may even change in whom we obtain CT scans, is the biomarker analyses, not only from those collected during the lung cancer screening trial, but other biomarker analyses. So the thought here being that taking the at-risk population and having a serologic test, having exhaled breath condensate, having some other measure before you even get your CT scan to identify whether that patient is at risk based on those biomarkers for lung cancer, and then using that as your first screen, and then taking those patients into CT and following them as CT screening. So I think some combination of biomarker evaluation as well as CT screening will be forthcoming in the future. And then we also have to remember that patients get to where they are in the screening process through their smoking. And so as a big component, I think, of our screening programs going forward for those people that are still smokers, that smoking prevention and cessation still have to be stressed and be a critical component of any lung cancer screening program. I think that's it.